Well, good evening, everybody, and welcome to this evening's webinar on antimicrobial stewardship. And I would like to say that this meeting is being recorded, but will only be used to gather information about any questions that you may have and that we can answer at a later date. Firstly, I'd like to start off acknowledging the traditional custodians of the lands on which we meet, Kaurna people here in Adelaide, South Australia, and I pay our respects to elders past and present, and also any Aboriginal or Torres Strait Islander person who is attending this webinar as well. Okay, so what are our objectives for tonight's webinar? Well, we're part of a group that is actually running a study around antimicrobial stewardship. And it may not be news to you, but over 10 million Australians receive antibiotics annually, often for self-limiting infections. Despite strong evidence for antimicrobial stewardship interventions, real-world uptake in primary care remains limited. The EASSI-PC study aims to close this evidence-based practice gap by implementing, evaluating, and scaling up co-designed antimicrobial strategies within general practice, tailored to real-world clinical settings. So and tonight is our first webinar, and as I said, it's going to be recorded and available to others. And the questions will be, and the answers to the questions that are actually delivered tonight will be posted on a website available next year. I would like to introduce three people who are helping us tonight, particularly with the questions that have been submitted and that you may want to ask online. And they are Parker Magin, who is a general practice researcher and former GP. Josh Davis, a staff specialist in infectious diseases and general medicine. And Maeve O'Sullivan, an editor and pharmacist at Therapeutic Guidelines. So I'm sure you'd like to welcome them all. And we would mention that if you do have any questions, you can post them on the website, and they will hopefully be answered tonight if we have time. The first part of the webinar will be a guidelines update, and Maeve O'Sullivan will be delivering this because she works for Therapeutic Guidelines, and that's been the starting point for some of our work. So Maeve, over to you, and the slides are coming up soon.
Perfect. Thank you, Nigel. Good evening, everyone. As mentioned, my name is Maeve O'Sullivan, and I'm one of the editors at Therapeutic Guidelines. So this is designed to provide an overview on the recent update to the antibiotic guidelines. To start with, the next slide will provide an indication of the size to the update. When the antibiotic guidelines were reviewed end-to-end last time for what we call antibiotic version 16, the content was split into two streams of work with two expert groups, Group 1 and Group 2. That review involved 36 experts and over 100 external reviews. Over the intervening years, it became quite clear that a different approach would be needed for the next update. Perhaps the most obvious factor was that the evidence landscape had become increasingly complex. For a comprehensive review of the guidelines, our expert groups would need to consider more inputs than ever. A subtler but no less important factor was that as the guidelines continued to expand in both the breadth of content they covered and the detail in which they covered it in, the topics had become increasingly diverse. Multidisciplinary expert groups are key to the Therapeutic Guidelines update process and help us make sure that our content is not only evidence-based, but also tailored to our users' needs. And having the right expertise in the room is critical to good decision-making. So with these factors in mind, we embarked upon an update that would allow us to have more people in the room, so to speak, which involved 6 expert groups, more than 100 experts, and multiple subgroups. The names are a little bit arbitrary, but I think give an idea of how variable the required expertise might be for each of these streams of work. I won't go into the composition of the groups or the topics that they reviewed, but if you're interested in this, it's all available online. My next slide shows that from a high-level perspective, you can sort of see the geographical distribution of our expert group members across the country. The map shows the diverse locations from which our members contribute, ensuring a wide range of regional insights and expertise. In total, for this revision, we had around 119 experts. Increasing the size of the expert group has allowed us to get buy-in from experts from each state and territory, and more experts with relevant expertise. And then the next thing I wanted to draw attention to is how we manage decision-making across streams. There were obviously issues that crossed the different groups, or for which all of the relevant expertise wasn't present on a single group. So to achieve robust decision-making for these issues, we convened a number of subgroups, as you can see here. Again, some of the names don't quite do justice to the issues that the group discussed, so I'll expand a little on a few of them. The paediatric subgroup brought together all 18 of the paediatric representatives across the expert groups. This meant that the paediatric content was extensively revised and expanded. For antibiotic 16, the previous revision, because of having limited paediatric expertise, the experts relied on review of the content out of session by their colleagues or input from professional groups such as ANSPID. With 18 paediatric experts on this revision, we've held complex clinical discussions, ensuring our recommendations reflect true consensus and can be integrated into practice. The microbiology subgroup consisted of clinical microbiologists and pharmacists with PK/PD expertise. They considered UCAST and CLSI guidance and a number of other inputs to review use and dosing of various antimicrobials, including amoxicillin plus clavulanate, ceftriaxone, and cefotaxime. The multi-drug resistant subgroup collaborated on the development of a new topic that gives guidance on how to manage a patient suspected to be infected with the multi-drug resistant pathogen. So in the March release, content reviewed by the hospital, primary care and drug information streams was published. Content from surgical trauma and perinatal infections, immune compromised, tropical and rare infections are slated to come out soon. Due to the expansion of expertise within the groups, as I've mentioned, there's been a significant amount of review. So to provide you a snapshot, this is a list of our new topics that were released in March. And then if you would like to learn more about the content, you can navigate to the address on this page to read our What's New, which was written by the editors of the individual topics. I'd also like to highlight some of the other content that is available on the updates to the antibiotic guidelines. There is a two-part series podcast available on Australian Prescriber on the updates. We also hosted a pre-conference symposium before the ACID annual scientific meeting on updates to the antibiotic guidelines. There are 11 presentations available on our YouTube, and I encourage you to check them out if any of the topics interest you. There's also a podcast available on the GP show, which focuses on updates to advice on conditions primarily seen in primary care. So in summary, this has been our biggest update ever, and it's been so exciting to have so many experts on the groups, some of whom are tuning in this evening. We're extremely grateful to have their expertise in guiding so many complex decisions. Take a look at the new content. There's more to come out very soon, and please subscribe to our updates page to get notified of future updates. Thank you.
Thank you, Maeve. And that's a very good summary of what has been happening in the background for a lot of us. Can I just ask before you leave, if you had one takeaway message for us and for the group that is dialed in tonight, what would that be around, antimicrobial stewardship?
That I think the number of experts needed to reach true consensus and support that those AMS principles is really key and has been a huge part of this recent revision.
Right. So you've actually had good buy-in from all the people around Australia who've contributed.
Definitely, and a really good mix as well. So the primary care group that I was involved in had quite a few GPs on the group alongside ID physicians, and it was just, really great to see that kind of consensus reached.
Great. So we can be assured of the integrity of all the decisions that have been made and that we are if we follow the ETG, that we are following the best practice guidelines for antimicrobial prescribing.
Exactly.
Very
Yeah.
good.
Can I add something to that?
Oh, please do, Josh.
Just as I'm one of the many people on the expert working group, but have been for about 15 years. So thinking how it works now to 15 years ago, most of the topics 15 years ago, there really wasn't much evidence to guide the decision. So it was much more expert opinion driven. Whereas nowadays, a large proportion, not all, but a large proportion of the recommendations are actually based on high level clinical evidence. So mirroring or echoing what you just said, that when people see a recommendation in the therapeutic guidelines, not only is it probably evidence-based, but it's been very carefully thought about and debated and crafted and all of that kind of stuff.
I
Right.
totally agree, Josh. Some of our evidence critiques are pages long.
Thanks very much, Josh, and thanks, Maeve, again. And I'll let you get off to your other commitments this evening. Thank you very much. Right. Well, we're going to continue this evening with a panel discussion. Unfortunately, we are one person down, and I just have to acknowledge that Professor Kirsty Boosing who's an infectious disease physician at the Victorian Infectious Disease Service at the Royal Melbourne Hospital, unfortunately can't be with us tonight. And so we're relying on Parker and Josh to answer the questions that were submitted prior to this evening. We'll also hopefully get to any questions that you might submit tonight. But I'll lead off with one of the first questions to Josh, and it's to do with urinary tract infections. And what is the background to the change of first-line therapies for urinary tract infections, Josh?
So there's probably one major and then a couple of minor things that have happened over the last few years that meant the guidelines needed to change. And I'm talking specifically here about cystitis in non-pregnant women. So the most common UTI that presents in general practice. And so one of those is the increasing emergence of resistance to trimethoprim. So trimethoprim was previously the first line recommended antibiotic for cystitis. But over the last 1 to 2 decades, E. coli, which causes about 90% of cystitis UTIs, has gone from about 10% of it being resistant to trimethoprim to now between 20 and 35%, depending where you are in Australia. So it's kind of reached the point now where it's not really fit for purpose as a first line antibiotic for UTI because, there's about a 1 in 3 chance that the organism is resistant to it when used for empirical use. So that's the main thing that changed and why the guidelines were changed. The second thing is fosfomycin, which is a kind of maybe a new antibiotic to most of us, became available in Australia about 5 years ago. And previously it hasn't been registered for use in Australia, but it has been used in Europe for decades. And cystitis is treated with a single dose of fosfomycin. And we can talk about pros and cons of that if we have time later. So that's the second change. And then the third one is there's been probably 3 or 4 randomized trials in the last decade. One was comparing nitrofurantoin to fosfomycin, showing nitrofurantoin superior. And then the others were about treating with a symptomatic treatment versus antibiotics. And again, we might come to those later. So, so all of those changes happen in the background and they've all been kind of rolled into this new update.
Great. Thanks, Josh. And that, I suppose, leads into a further question which somebody posed, and it's around barriers to prescribing. And they said, have found nitrofurantoin to be unavailable. What to do?
Yeah, that's interesting. I'm not sure. I mean, I work in a hospital, right? So I don't really know what the availability is like in community pharmacy land. It is on the PBS. My suspicion is, it's not been that commonly prescribed before this year, but it will be prescribed a lot more now because of the guideline change, and therefore pharmacies will catch up with that and it will become available. But, if you've got a patient in front of you and nitrofurantoin's not available at your local pharmacy or in your town or whatever, then I would just go down the list. In therapeutic guidelines, there's first line, second line, third line recommended antibiotics. So first line is nitrofurantoin for cystitis, second line is fosfomycin third line is trimethoprim, and fourth line is cefalexin. So I'd just go down that list until you find one that is suitable for your patient and available.
Yes, unfortunately, the phosphomycin is costly because it's
Yes.
basically a private script.
Exactly, yeah. So unfortunately, it's not on the PBS. There is a lot of work going on behind the scenes to try and get that to happen. It's quite expensive. It's about $50 for a single dose. On the plus side, it was $120 for a single dose
My
about
goodness.
up until about a year or two ago. Um, so yeah, m many people can't afford that, but it's not dissimilar to the price of a the co-payment on a normal prescription for someone who doesn't have a healthcare card. But yes, it is unaffordable for a lot of people.
Fine. And I guess that leads me into another question which somebody has posed. What about the evidence for NSAIDs rather than antibiotics for urinary tract infection? Because, well, that solves the problem of shortages of antibiotics and expensive antibiotics. So, because NSAIDs are pretty available and quite
Yes,
cheap,
yeah.
relatively
So
speaking.
so it was kind of a radical idea. It's seen as a radical idea in Australia at least, but in the Netherlands and in Switzerland, where the two randomized trials were done, they have a much more judicious approach to antibiotic use than we do in Australia in
Mm,
general.
mm,
So in those two countries, two different randomized trials have been run, both in women with uncomplicated urinary tract infection, so not pyelonephritis and so on, just cystitis. And in both trials, women were randomized to either get antibiotics. It was different in it. One was fosfomycin, one was nitrofurantoin, I think, or no antibiotics and just regular ibuprofen as symptomatic treatment. Um, and in both groups, at the 7 day mark, basically the same proportion of women had recovered from their UTI. Um, the women in the group that received antibiotics did recover a little bit faster. So at day 3, they were more likely to be symptom free than the ones without antibiotics. But at day 7, there was no difference. The little caveat in that and why it hasn't become like really widespread first line, like for bronchitis and sore throat and otitis media, for example, first line is no antibiotics because it gets better without. For UTI, the reason it hasn't become very widely recommended is because the risk of pyelonephritis as a complication, in the week or two following, was statistically significantly higher in the group that did not receive antibiotics. However, it's still a rare outcome being between 1% and 1 in 1,000. So somewhere between 1 and 10 in 1,000. Um, so if you do not receive antibiotics, there is a higher risk of ending up with pyelonephritis, but 99% of women do not end up with that. And pyelonephritis is, easy to treat and usually responds pretty quickly. So that's the reason why there's a bit of reservation about recommending it.
Yeah, I guess it's somewhat of an option for those samples that come back as negative for any growth at all, and often on repeated occasions for the same person, woman in the main.
Yeah.
Any views on that?
Well, those trials make me and others who wrote the guidelines really comfortable with the idea that if, say, you've seen a patient, a woman, you've given her, let's say, trimethoprim or nitrofurantoin or whatever, and then 3 days later you get the culture result back and they've got an E. coli resistant to that. In the old days, you would have said, "Oh, quick, I better recall her. Now I'm going to give her a different antibiotic, augmentin or whatever that's sensitive to." However, the recommendation now is if you speak to the patient or recall them and they're getting better, don't worry. Like, yes, their isolate was resistant to that antibiotic, but they probably didn't actually need it in the first place.
Hmm.
Um, there are different ways in which people recommend using this idea of the non-steroidals. In Europe, it's kind of the first line, they push it a lot. Um, Here, I think the recommendation is have a discussion with your patient about their values and wishes. And one thing to think about is is delayed prescribing. So, giving a prescription for nitrofurantoin and say, look, just take regular ibuprofen, drink plenty of water, etc. And if you're no better in 3 days, then start this antibiotic. And if you do that, a large proportion, something like 60 to 70%, end up not needing the antibiotic.
Great. Thanks, Josh. I'll come back to you. So, Parker, you get the next question. So we break it up a little bit. This person said, "Hi, I just wanted to ask a question around otitis media. Is there any rationale to start earlier for kids who have frequent episodes, or is the evidence still to withhold for at least 48 hours for each episode?" Parker, you're on mute.
Yeah, so the Therapeutic Guidelines recommendation are to treat it as de novo, not with immediate antibiotics. Although certainly the ROCGP in a recommendation for GPs, which I checked and is still current, suggests that that may be reasonable to treat earlier in a child who's had previous otitis media, recurrent otitis media, that they define that as more than 3 episodes in the previous year or more than 2 in the past 6 months. So I think it comes down to the most reasonable thing is to go by the Therapeutic Guidelines. But again, that's possibly something that shared decision making with the parents would be reasonable, and it may well depend a little bit on how severe those episodes have been in the past. But in general, I think it's wise practice to stick to the recommendations in Therapeutic Guidance, all else being equal.
Yeah, that's interesting, isn't it? Because I know in the Netherlands that they have pretty universal non-use of antibiotics for otitis media, and they have similar complication rates to everybody else. And so it's an interesting aspect of how things have evolved in different countries. Because having worked in the UK, I found that there was a lot of pressure to prescribe antibiotics, even though we were just across the water, the channel from Europe. But here in Australia, we seem to have adopted the English way of doing things. So, yeah. And of course, we can still use delayed prescribing because, when you have a mother and child come in on a Friday afternoon, it's very hard to say, no, just wait 48 hours, because getting in on a Monday is actually fairly difficult, although I suppose they could do telehealth these days.
Yeah, well, I think delayed prescribing is a really useful tool in multiple situations, and certainly it's something that our registrars find really useful. That option that gives them especially they often don't know the family as well as perhaps their supervisor would, and they see the child, and it's a little bit harder for them to push a line. So for them, delayed antibiotics is often a really useful option when it's reasonable. Yeah.
Great. The second question was, is there any actual evidence for the use of honey in cough and sore throat as an adjunct to avoiding having to prescribe antibiotics?
Yeah, the simple answer is yes. That it's certainly in the handy guidelines from the college, and there's pretty reasonable evidence that it reduces the severity of symptoms, and also a little bit of evidence that reduces the duration of cough. So it's certainly a really viable option in kids older than 12 months for cough. It's not recommended under 12 months because of smaller kids have less immune response, and there's some concern about botulism. But it's a really and from my previous anecdotal experience, parents really like it, and it seems to work in real life as well as in those trials.
And kids really like it.
Yeah.
Well, I work as a GP up in the Adelaide Hills, and in an area which has a fairly significant conscientious objector population, which is not so good for vaccinations, but pretty good for not having a preference not to use antibiotics. And occasionally I've had to actually encourage the use of antibiotics when appropriate. So it really is horses for courses sometimes in general practice. And, we tend to know our patients reasonably well, and who is favourable to perhaps delaying antibiotics or not having them at all, but others who are fairly insistent as well. And I guess people may in the audience would have their own anecdotes about that circumstance. The third question was, could you please comment on how to approach patients who request antibiotics to take overseas in case they become unwell?
Yeah, I think that's again that can be a little bit nuanced. The simple answer is it's not really a very good idea, and I understand there's some evidence that people don't use antibiotics appropriately when they are given for use if needed overseas. And certainly the Therapeutic Guidelines no longer recommend using antibiotics for diarrhea, for traveller's diarrhea, which would be one situation. There may be situations. So, for instance, and probably they're no different to self-treatment in Australia. So, non-pregnant females who have had recurrent UTIs, it's probably quite reasonable when they're travelling to have a script for that. There may all, again, it's always considering the situation. So there may be people who are going to be in areas where they really don't have access to healthcare, and also maybe in situations where they're more likely to get injuries and perhaps then infection, cellulitis. Very special circumstances. You could work out with a patient that may be appropriate, but again, have to be very clear instructions to patients in which kind of situation. But again, my own experience was most when people asked for that, they wanted antibiotics for if they got respiratory tract infections, self-limiting respiratory tract infections. And I think again, that question was about what do you talk to patients about? Well, I think they're concerned, I'm going to get a cold. If I get a cold, I don't want it ruining my hospital, my holiday. But I think if you get sort of diarrhea or a sort of allergic rash, that's going to have more effect on your enjoyment of your holiday than would a self-limited cold. The other thing, though, is if you do take drugs overseas, the department strongly recommends making sure that you have either a script for it or a letter from the doctor specifying the drug and the dosage, etc. And to also always keep the drugs in their original package. So that obviously goes not just for antibiotics and probably more so for other things. But again, remember that if there is a situation where you feel it's appropriate for the patient to take some antibiotics.
Great. Thanks, Parker. I'd like to remind the people who are participating in the webinar that you can post questions in the chat box, and you just and we will then attempt to answer them. But you have to put them up there in the chat box to be able to for us to be able to see them. And I'll direct another question to Josh, which was how to tell if community-acquired pneumonia is due to bacterial, viral, fungal, or other cause.
So the short answer is you can't. And if you read old-fashioned medical textbooks, they talk about the typical clinical and X-ray presentation of pneumococcal pneumonia, let's say. But what's become clear over the years is that really yes, there are typical presentations, but most people don't have those. And people with influenza or other causes of viral pneumonia can have solid lumps of consolidation and coughing up purulent sputum. People with pneumococcal pneumonia can present with vague, streaky changes on the chest X-ray and clinical findings that are indistinguishable. So pneumonia is a good example of a condition that is treated with a syndromic approach. So all we can say clinically and even with imaging is that the patient has pneumonia, yes or no. The only way of knowing for certain if there's a particular organism involved is microbiological testing. And even that is sometimes not definitive. So, for example, in people that are admitted to hospital with severe pneumonia, we do blood cultures, sputum cultures, and multiplex respiratory PCR. And even with all that testing, around 40%, only around 40% of people with pneumonia end up with a kind of organism-based diagnosis. So 60%, we never find anything on those tests. And even if we do find something, it may or may not be the pathogen. So, for example, if we find a rhinovirus on a PCR, they may have had a cold and now they've got a bacterial superinfection. They may have a viral pneumonia. So, the bottom line is, particularly in the community setting with mild to moderate pneumonia, it's not worth trying to agonize about what the cause is. You just take the syndromic approach and use the recommended antibiotic treatment for mild to moderate pneumonia.
Very good, thank you. Mina, I was just wondering whether there was any particular questions that have come up. I can't see any in the chat.
No questions.
No, that's okay.
Okay.
That's fine. I'll ask a question without notice to Josh and Parker, but and I'll try and answer as well if I can. What does effective antimicrobial stewardship look like in a setting where nurses are the primary on-site clinicians? And that could also be applied to pharmacy, where we are having pharmacists prescribe antibiotics, at least for urinary tract infections. They have a strict protocol, apparently, but presumably that will change. I'm not sure. So just any general comments about that, because it did seem to me that one of the things that you wouldn't do if you were trying to reduce antimicrobial resistance is to open up prescribing to a lot more people, because more people will then be prescribing potentially when it wasn't required, and without better controls, it could lead to more difficulties in the future.
Do you want to take that first, Parker?
Yep, sure. That's a little bit awkward question. I think I have some misgivings about that situation, because presumably you're talking about treating common conditions, but common conditions, their diagnosis is not always easy. And when we think about antibiotic stewardship, certainly one of the things we've found with registrars, with qualitative studies, and also looking at some quantitative studies of actual prescribing, is that diagnostic uncertainty is a driver of antibiotic prescribing, and that's seen especially for respiratory tract infections, and less experienced clinicians, and we talk about registrars here, look to antibiotics as the default if there's uncertainty, and there's some natural concern about missing diagnoses and etc., which are not founded in evidence, but they're understandable. So I'd have concerns about even less experienced diagnosticians prescribing antibiotics, because I think it's likely that uncertainty may well drive antibiotic prescribing, where a more experienced clinician would be happy not to. But that's not based precisely on evidence. That's my feeling for how it might be.
Well, I mean, from the nursing point of view, I have worked with nurse practitioners who can prescribe, and in my experience, they're actually the people that follow the guidelines the most. So unlike doctors who think we know better, right? So generally, as long as prescribing is limited to those who are qualified to do it, like nurse practitioners, for example, I don't think that's really a problem. Stewardship. From the pharmacy point of view, that's a lot more controversial. And I know that I know it was the AMA, I think, rather than the College of GPs were pretty against this. But as people are aware, there's a trial of it happening in New South Wales and Queensland currently, and it's being evaluated, the effect of allowing pharmacists to prescribe not just for UTI, but in fact for an expanding range of conditions, including some skin problems and ear things and lots of things. So it's kind of a watch this space to see how well it works. I also have some reservations because pharmacists can't order pathology tests, for example. So it's impossible for them without sending to a doctor to do a urine test. And even though a urine MSU is not recommended in all patients in terms of uncomplicated first presentation, it needs to be available for treat someone properly as an option at least. Anyway, but time will tell. And yes, the I am aware that there's discussions right now to change the prescribing guidelines for pharmacists for UTI according to the new TG. I don't think it's quite come in yet, though.
Yep. Thanks very much. I think we do have some more questions on the Q&A area. So one person has. Oh, sorry, Maeve?
No, I was just gonna to let you know about the
Yeah.
questions as well.
Yeah. I found them. So we're not letting the panel off just yet. Okay, so somebody had recently watched a webinar from the RACGP about a point of care test to tell the difference between a bacterial infection and viral infection. Are you aware of these newer point of care tests?
I don't know exactly what test was being spoken about in that webinar. It may be that there are point of care C-reactive protein tests, CRP, but CRP is not a reliable way to differentiate bacterial from viral infections. People with influenza can have a CRP of 150. People with severe bacterial pneumonia can have a CRP of 20, and then the next day it's 200. So it does change the probability, but it's certainly not particularly specific. There are point of care antigen tests, for example, like everyone knows about for COVID, and that they exist for flu, RSV, and then there are other viruses that antigen point of care tests can be done. But again, there's no point of care test I'm aware of that is sufficiently sensitive or specific. They can kind of guide you a little bit one way or the other. But Parker, do you know what test they were talking about?
I suspect CRP because there's been quite a lot of research in England and Europe with CRP for respiratory tract infections, and the evidence there was that it did change the probabilities somewhat, and there was and so people feel there is some evidence, but I don't think it's not available in Australia, is it?
No, so Stephen has said it's not CRP, it's February DX. I don't know what February DX is, but I'll look into that, Stephen, and find out.
Yeah. I think, as I understood, I had a visiting professor from Tromsø in Norway some years ago who was very keen on using CRP, as were a lot of Scandinavian doctors, to try to differentiate between bacterial and viral. But I'm not sure that it's been widely accepted beyond those nations. I'll go on to another question because I think this is an interesting one. Can we talk a little bit about the value of finishing the full course of antibiotics? It used to be recommended that you should finish the complete course even if you no longer had symptoms, and now there are evidence that you don't need to. And does it affect antimicrobial resistance?
Yeah, that's a really good one. And that's a really good example of how kind of wisdom has changed over the last couple of decades. Is like probably all of our mothers have told us you must finish your course of antibiotics. But I guess there's two things that have changed a lot based on evidence. One is the recommended duration of antibiotics for most conditions has become shorter and shorter. Like for community-acquired pneumonia, it's 3 to 5 days now, and a lot of trials showing 3 days is probably sufficient as an example. And secondly, there's been one randomized trial I'm aware of in New Zealand in the primary care setting where patients were randomized to complete the course of antibiotics or to stop the antibiotics as soon as they kind of felt clinically better. And the second group stopped them on average after about 3 days, the first group after about 7 days. This was about like 600 patients who had various suspected bacterial infections in primary care. and their outcomes at 30 days in terms of complete clinical recovery without needing to go to hospital was exactly the same in both groups, and the side effects were less in the group that stopped early. So I think finishing the course is important if you're prescribed an evidence-based duration. Like if you're prescribing 3 days for something that only needs 3 days, they probably should finish the 3 days. But if you're prescribing 7 days plus one repeat, then it makes sense to finish the antibiotics once the patient is clinically improved. The feared consequence of encouraging resistance of having a short course is, firstly, it doesn't make theoretical sense, and secondly, it just hasn't been observed. People have looked hard for this in randomized trials of shorter versus longer courses, and if anything, the longer the course is, the more likely a resistant subpopulation of bacteria is to emerge.
Great. Look, thank you. I think we've come to the end of the time that we can spend on the panel discussion. And I would like to ask both Josh and Parker to potentially give us a takeaway message, just like Maeve did, about tonight and about antimicrobial stewardship.
I'll think of mine while Parker says his.
Well, I think a couple of things have come through there. One is that really solid evidence-based guidelines, like therapeutic guidelines, for the great majority of people, the great majority of times, are going to guide appropriate management, and that really will aid antibiotic stewardship. Occasionally, there will be things that are it's a square peg in a round hole, and sometimes, occasionally, there may be different situations, but the great majority of times, as Josh said before, the evidence is now there, and it's been curated to help us as GPs. And a second thing I think is something that Josh raised about treating syndromically, and not worrying or realizing that you can't consistently make a judgment of whether something's viral or bacterial. And what we really need to do is to treat syndromically, because that's what the trials that the evidence is derived from are based on treating syndromes. So I think, again, not to get too caught up in the idea I must be able to tell whether this is viral or bacterial, but rather to treat the syndrome.
Great, thanks, Parker. Josh?
Yeah, mine would be that don't forget your patient, or most of them, have an immune system. And the role of antibiotics in bacterial infections is not to kill every bacteria that's causing the infection. It's just to shift the balance in favor of the host, just to give a little nudge along to their immune system, which is actually what's doing the work and making them better. So in other words, in most mild to moderate bacterial infections, antibiotics are an adjunct, they're not the treatment. So and that's why we can get away in most conditions without using them. The patient will get better without them. In severe infections, it's a different matter. But in mild to moderate, most patients don't need antibiotics. No one will criticize you. Like, as a hospital doctor, we would not think badly of a GP if they followed the therapeutic guidelines, did not use antibiotics, and the rare patient ended up, severely ill, needing hospital admission. No one will criticize you for that because you've followed evidence-based guidelines.
Thanks for that reassurance, Josh. And thank you both for being part of our panel. And we're going to move on now to a 5-minute presentation by Professor Paul Glasio, who is one of the chief investigators for the EASSI-PC trial. And this is a recorded message because Paul couldn't be with us tonight. And it's about what the study, EASSI-PC study, is about. I'm sure it's going to start in a second.
Hello, I'm Paul Glasgow. I'm a GP researcher and I've worked for several years on trying to reduce antibiotic prescribing in primary care, and I'd like to talk to you about the EASSI-PC trial. As a GP, I once thought that antimicrobial resistance was only a problem in hospitals, but several studies made me realise that resistance is equally a problem in primary care, and in my patients, and even in me. Most courses of antibiotics will cause some resistance, which may reverse over months or years, but the resistance leaves patients vulnerable meanwhile. That resistance also goes with our patients into hospital, and roughly half of the resistance seen in hospital has arisen from antibiotic use in primary care. So, what can we do? We can't stop using antibiotics. Sometimes they're essential, but we can work step by step to use them more judiciously. Such wise use will reduce the risks to our patients of adverse effects and of resistance, while reserving antibiotics for cases where there is a clear benefit. So, as a practical step forward for primary care, a new 4-state MRFF study called EASSI-PC, led and co-designed by GPs, is testing a variety of strategies to help GPs with this judicious use of antibiotics. We want to see what helps and what's feasible. The types of strategies that we will test include delayed prescribing, patient information sheets, shared decision-making, practice policies and posters, audit and feedback, and learning how to use clinical prediction rules as a guide for targeting the right patients. Over the next 3 to 4 years of the study, we will evaluate and refine these methods with the aim of taking the strategies that we find feasible and useful into an ongoing national program. We want to reduce antibiotic use to the minimum, but with no additional burden for busy GPs. And we'd love your advice, your feedback, and your participation in the EASSI-PC study, and look forward to working with you over the coming years.
Great. And that was Professor Paul Glasgow, who has made a great contribution to the area of antimicrobial stewardship, and particularly through the Cochrane Respiratory Group, which I think he was chair for a number of years, along with Professor Chris Delmar. Okay, so we're coming to the end of this particular webinar. I hope it's been of interest to you. We would like to ask you, or at least invite the GPs who attended this webinar to complete a brief 5 to 10 minute survey about their current practices. And you can see the QR code here if you'd like to scan that. And by completing the survey, that will help us shape a more tailored and practical GP-driven strategy that will guide our trial next year. At the end of the survey, you will have the opportunity to register your interest if you would like to hear more about the trial and receive different planned incentives if you participate. So we appreciated your attendance here tonight, but if you do have 5 or 10 minutes to do the survey, that would be fantastic. I also want to state that we will be having a newsletter and website up next year, and that our first newsletter, which will include the link to our website as well as a link to this webinar recording and answers to the questions that we could not get to during the webinar, will be circulated through the primary health networks. In the same way you received the advertisement about this webinar. Of course, you may have been contacted in a different way, but we will certainly be in the areas in the 4 states that we are operating the study, that the PHNs are cooperating with us to disseminate information to practices and GPs. So I think that's it for tonight. Hopefully you can have an extra 7 minutes to do the survey. And that way you can use up your full hour. So again, thank you for your attendance. And hopefully we will potentially involve you in our EASSI-PC study next year. And at the very least, you will be able to access our newsletters and our website to obtain more information about antimicrobial stewardship. So thank you and good evening.